Topic number 12. Acute and chronic disorders of arterial blood circulation, thrombosis and embolism of the main vessels. Lecturer Shevchenko Alexander, Baltic Federal University Medical Institute, Kaliningrad, 2020. First of all, arterial occlusion and acute arterial insufficiency. Acute arterial occlusion is a condition that results from the sudden arrest of the blood flow in artery and is the commonest cause of gangrene. The factors that contribute to arterial occlusion include trauma, the excessive pressure from a tourniquet, intraoperative ligation, and the artery thromboembolism, which is a known cause. Thromboembolism causes the following pathogenic changes: obstruction of a main vessel, acute distension of the vessels above the area of obstruction, reflex spasm of all the arterial network of the limb, the obstructed vessel, its branches and collaterals beneath the area of obstruction, formation of a sequel thrombus beneath the area of obstruction because of a decrease in blood flow, and defects of blood coagulation and anticoagulation system. According to Saveliev, the clinical course of thromboembolism of the major vessels divides into 3 stages. Stage 1. Ischemia, causing functional disorders. This lasts a few first hours. The clinical picture includes acute pain in the limb affected, pale and cool skin, free absent pulse of the peripheral arteries. It is noteworthy that pain and touch senses usually remain intact. Active joint motions are slightly limited. The restoration of blood supply to the limb at this stage leads to a full functional recovery. Stage 2. Structural changes include such signs as absent pain and touch sensations, markedly limited active and passive joint movements, muscular edema and contractures, bluish discoloration of the skin. This stage lasts for 12 to 24 hours. The restoration of blood supply within the above-mentioned period can save the limb, although its functions are as a rule either partially or fully lost. Stage 3. Necrosis is characterized by the development of gangrene. It falls within 24 to 48 hours after embolization. At this stage, due to gangrene, virtually all forms of sense and movement will be lost, while resume of the blood flow in the vessel can occasionally reduce the level of the demarcation line and the level of amputation. The staging of ischemia helps choose the therapeutic modality. Stages 1 and 2 require radical treatment, restoration of the artery patency, restoration of the blood flow. Stage 3 precludes the aforementioned therapies. The necrosis of the extremity is a life-threatening condition, and this calls for urgent options. Of this, the amputation of the limb affected being the mainstay. Clinical findings. Vital signs: increased pulse rate, low blood pressure, labral and mucosal cyanosis, fast breathing. Skin changes. A change in skin colors, which becomes cyanotic, pale or even white with bluish patches, the marble skin, that resembles those of the cadaver. Coolness to touch is more pronounced at the peripheral areas. Skin temperature is reduced by 2 to 3 degrees of Celsius as compared to that of the intact side. Both pain and touch sensations checked with a needle are diminished. The inability of the patient with their eyes closed to distinguish between being prickled by a sharp object and touched by a blunt one indicate the loss of both pain and touch sensation. This suggests irreversible damage to the tissue, as the circulation in the limb fails to maintain the viability of tissues. On the picture you can see color of the marble skin. Absent lower limb pulse is a typical sign, and neurologic signs. It should be emphasized that neurological signs, numbness, sensation and paresthesia with subsequent loss of all kinds of sensation, become visible very fast. The pain can shortly be followed by motor deficit of various degrees, finger and toe paralysis, the combination of pulselessness with paresthesias, acute pain, pallor and palsy are therefore diagnostic of acute arterial ischemia. The patient with arterial thromboembolism are usually those with serious cardiac disease. May be or may not be, but you must check out this. Diagnostic approach. First, the examination must occur in a warm room. Second, it is required that the symmetrical sides of the limbs be inspected. Skin color is compared on both limbs. Pale or violet bluish discoloration acquired on moving the limb from the horizontal position to the vertical one strongly suggests deficient circulation. The skin is usually dry and scaly, and the nails are deformed, thickened and brittle. A loss of air and muscle atrophy may also be observed. The feeling of the arteries shows a weak or absent pulse on the lower limb. The pulse is to be felt on the femoral artery below the middle of the Puppar's ligament, popliteal artery in the popliteal fossa, with the leg flexed in the knee joint and the muscle maximally relaxed, dorsalis pedis artery between the first and second metatarsalis bones, and tibialis posterior artery behind the medial malleolus. Pulsation on the upper limb will be evaluated on the subclavian, humeral and radial arteries. To assess the severity of arterial circulatory disorder, special tests are performed. OPEL test. Have the patient lie supine with his/her leg raised at the angle of 45 degrees, the appearance of paleness on the sole, the plantar ischemic sign, shows as the evidence of arterial circulation insufficiency. Saveliev test. Have the patient lie in the position as described above and do 20 to 30 flexions in the ankle joint. The appearance of paleness on the sole is also a sign of arterial circulatory insufficiency. Mashkovich test. Have the patient lie supine, raise his/her leg and apply a tourniquet for 5 minutes. The period needed for the skin to regain hyperemia following the removal of the tourniquet is normally 5 to 30 seconds, whereas in arterial occlusion is as long as 3 to 5 minutes. The above-mentioned tests can only be diagnostic at initial or compensated stages of the disease. If intermediate claudication appears, the diagnosis is easy to make. The sub- decompensation stage of circulatory failures. Special methods. First of all, thermometry, the technique of measuring skin temperature at symmetrical limb areas using an electric thermometer. A reduction in temperature by 0.5–0.7 degrees Celsius strongly suggests deficiency in the blood flow. Oscillography, recording oscillation produced by changes in electrical potentials caused by vibration of an artery. A decrease in vibration amplitude indicates deficient circulation. Impedance radiovasography, the technique to register the resistance produced by pulsating limb arteries as a result of their filling in health. The radiological index is as high as 0.8, 1.0. Its reduction being evidence of deficiency of the arterial circulation. Doppler ultrasound, the method of listening to the arterial blood flow with a velocity detector, Doppler probe, to recognize arterial occlusion or stenosis. 5. Capillaroscopy, microscopic examination of the capillary vessels of the skin or nail beds. In occlusive arterial diseases, the capillaries become convoluted, winding and constricted. 6. Arteriography, the visualization of arteries by means of X-rays after injection of radiopaque material. In obliterating atherosclerosis, the vessels with the eaten up internal contours as well as the areas of the constricted or occluded lumen are seen. In the arteries, the arterial lumina are markedly narrowed, often over wide areas. Thrombosis or thromboembolism cause obstruction of the artery. The management of the patient with arterial thromboembolism must be individualized depending on, first, the location of the embolus, second, the stage of disease, and third is duration. The perioperative treatment should start with conservative measures, failure of ischemia to subside, and that of pain to relieve and touch sensation to recover within 1.5 and 2 hours. Other therapy is an indication for surgery. The conservative treatment is applicable at initial stages of the disease, within 6 hours from its onset of disease, in critically ill patients, in embolism of small arteries, those of the foreleg and forearm, in obscure clinical picture. As method additionally to surgery, it involves the following: anticoagulation therapy, heparin or indirect anticoagulants, and fibrinolytic agents, streptokinase, streptodecase, and urokinase, to prevent formation of clots and lead the performed ones. Open procedures. Shunt operations. We see on the picture two shunts. First, made from the vessel. It is a vein, and second one it's artificial prosthesis. And another type of procedure is thrombectomy and thrombectomy. When we perform thrombectomy, we made incision on the arterial wall, insert special catheter into the lumen of the artery, and destroy or take out the thrombus. And if thrombus is very sticky to the intima of the vessel, we provide thrombectomy. It means we incise the wall of the artery and replace it by the artificial tissue. Here we see thrombectomy, but this in case of atherosclerosis of the carotid artery. We have three main endovascular procedures: angioplasty, stenting, and arteriotomy. Here we see balloon angioplasty with stent placement. It's balloon angioplasty here, and different types of arteriotomy. We can use direct incision with the sharp edge of the catheter, rotational. This balloon can scratch the inner wall of the artery with thrombus, and transluminal extraction. Here we have sharp edges which destroy the thrombus, and laser. Chronic arterial occlusion. Chronic arterial occlusion is a condition caused by the gradual narrowing of the artery with the resultant ischemia of the limb. Possible causes: obliterating atherosclerosis and thromboangiitis obliterans or Buerger disease. Causes of chronic ischemia of the limb include the following: thromboangiitis obliterans, endarterism or Buerger diseases, and Gangrenous disease. Thromboangiitis is the inflammation of the entire wall and connective tissue surrounding medium-sized arteries, and views especially of the legs of young and middle-aged men. Venous disease has a vasospastic origin and affects mainly the upper limbs. Obliterating atherosclerosis that results from atherosclerotic narrowing and occlusion of the vascular lumen. It is chronic arterial insufficiency that underlies each of these diseases and produces the ischemic syndrome. The diagnosis is based on the degree of the arterial insufficiency and its progression rate. Taking history: pain It is usually the earliest complaint. Intermittent claudication, severe pain in the legs, tension and weakness on walking which makes the patient stop. The symptoms increase as walking proceeds until further progress is impossible, being the chief but late symptoms. It indicates pronounced disorder in the limb circulation, even though most patients associate it with the beginning of their disease. The severity of the symptom correlates directly with the degree of ischemia. First stage, non-limiting and non-permanent intermittent claudication, characterized by increased sensitivity to cold, cramps and paresthesia, reduction of hair on the limb, and delayed nail growth, weakening of the pulsation of the feet. Stage 2, divided into two substages, A and B. A. Distance without pain at a normal step more than 200 meters, and B. Distance without pain less than 200 meters. Second stage, called limited and intermittent claudication. Stage 3, pain at rest. Pain appears at first at night, when lowering the leg down, characterized by gradually subsides. Hypospadic edema develops, and pale skin is characteristic, foot fatigue and cyanotic coloration of foot. Stage 4, gangrenous ulcerative stage, characterized by the appearance of ulcers and venonecrotic tissue changes. Physical examination. Giant pale skin with bluish patches of ulceration or forces of necrosis, and edema on one of the toes and fingers, thickened and brittle nails, muscle atrophy, absent arterial pulse on the feet, persistent and unbearable pain, marked edema and cyanosis, with bluish-black discoloration of the whole foot, wrinkling of the skin, which suggests dry gangrene, superimpressed infection, which leads to wet gangrene. Surgical treatment implies radical operations, embolectomy, arteroplasty, and vascular shunting to restore the patency of arteries, whereas palliative ones are performed to improve the collateral circulation without restoring the patency of the main vessel. Acute venous thrombosis, divided to deep venous thrombosis and superficial venous thrombosis. Deep venous thrombosis is the formation of a blood clot in a deep vein, most commonly in the legs or pelvis. Symptoms can include pain, swelling, redness, and enlarged veins in the affected area, but some deep venous thrombosis have no signs. The mechanism of clot formation typically involves some combination of decreased blood flow rate, increased tendency to clot, and injury to the blood vessel wall. Risk factors include recent surgery, older age, active cancer, obesity, personal history and family history of venous thromboembolism, trauma, injuries, lack of movement, hormonal birth control, pregnancy and the period following birth, and antiphospholipid syndrome during the pregnancy. We have score which we can apply to assessing of the risk of the deep venous thrombosis. It calls Wells score. So if we have lower limb trauma or surgery or immobilization in a plaster cast, score +1. Bedridden for more than 3 days or surgery within the last 4 weeks. Tenderness along deep venous system, entire limb swollen, calf more than 3 cm bigger circumference and 10 cm below tibial tuberosity than another leg. Pitting edema, dilated collateral superficial veins, non-varicose, malignancy, including treatment up to 6 months previously, and history of deep venous thrombosis. We can use special diagnostic methods, ultrasound, CT, MRI, or we can use D-dimer. D-dimer it's indicator of thrombolysis, and if we have no D-dimer, it means we didn't have any thromboembolism. But if we have elevated D-dimer, it means it can be deep vein thrombose, but also it can indicate to many other conditions, pathological conditions. So conservative treatment. Treatment for deep vein thrombosis is warranted when the clots are either proximal, distal and symptomatic, or upper extremity and symptomatic. Providing anticoagulation is the typical treatment after patients are checked to make sure they are not subject to bleeding. However, treatment varies depending upon the location of deep vein thrombosis. For example, in case of isolated distal deep vein thrombosis, compression stockings and ultrasound surveillance and standard blood anticoagulation might not be used. Those with isolated distal deep vein thrombosis at a high risk of venous thromboembolism recurrence are anticoagulated and as if they had proximal deep vein thrombosis, but those at a low risk for recurrence might receive a 4 to 6 week course of anticoagulation, lower doses or no anticoagulation at all. Those with proximal deep vein thrombosis should receive at least 3 months of anticoagulation. Procedures: thrombolysis, the placement of an inferior vena cava filter, and thrombectomy. Thrombolysis is the injection of an enzyme into the veins to dissolve blood clots. And while this treatment has been proven effective against the life-threatening emergency clots of stroke and heart attacks, randomized controlled trials have not established a net benefit in those with acute proximal deep vein thrombosis. Drawbacks of the catheter-direct thrombolysis, the preferred method of administering the clot-busting enzyme. On the picture we see an inferior vena cava filter. The placement of an inferior vena cava filter is a potential treatment option when the standard treatment for acute deep vein thrombose anticoagulation is absolutely contraindicated, not possible. For example, if we have pregnant women. Superficial vein thrombosis is a type blood clot in a vein which forms a superficial vein near the surface of the body. Usually there is thrombophlebitis, which is an inflammatory reaction around a thrombosed vein, presenting as a painful in duration with redness. Superficial venous thrombosis itself have limited significance in terms of direct morbidity and mortality when compared to a deep vein thrombosis, which occurs deeper in the body and the deep venous system level. However, superficial venous thrombosis can lead to serious complications, as well as signal other serious problems, such as genetic mutation that increase one risk for clotting, and there is therefore no longer regarded as a benign condition. If the blood clot is too near to saphenofemoral junction, there is a higher risk of pulmonary embolism, a potentially life-threatening condition. Treatment: compression, physical activity. Inactivity is contraindicated in the aftermath of an superficial venous thrombosis, and anticoagulants, non-steroid anti-inflammatory drugs, or surgery. Surgical interventions include ligation of the saphenofemoral junction, ligation and striping of the affected veins, and local thrombectomy provided when the thrombosis is close to the saphenofemoral junction, and because it's high risk for thromboemboli of one artery. Chronic venous insufficiency. It's called post-thrombotic syndrome. We have two nosologies. First, post-thrombotic syndrome, and second, chronic venous insufficiency. Post-thrombotic syndrome, also called Post-phlebitic syndrome. And venous stress disorder is a medical condition that may occur as a long-term complication of deep vein thrombosis. Signs and symptoms of post-thrombophlebitic syndrome include pain, heaviness, itching or tingling, swelling, edema, varicose veins, brownish or reddish skin discoloration, and ulcers. Treatment options for post-thrombotic syndrome include proper leg elevation, compression therapy with elastic stockings, or electrostimulation devices. Pharmacotherapy, pentoxifylline, herbal remedies such as horse chestnut, rotosides, and wound care for leg ulcers. And chronic venous insufficiency is a medical condition in which blood pools in the veins, straining the walls of the vein. The most common cause of the chronic venous insufficiency is superficial venous reflux, which is a treatable condition. As functional venous valves are required to provide for efficient blood return from the lower extremities, this condition typically affects the legs. If the impaired vein function causes significant symptoms, such as swelling and ulcer formation, it is referred to as chronic venous disease. Signs and symptoms for chronic vein insufficiency in the leg include the following: varicose veins, itching, hyperpigmentation, phlebitic lymphedema, chronic swelling of the legs and ankles, venous ulceration, chronic veins infection or insufficiency in the legs, may cause the following: penostasis, ulcers, static dermatitis, and known as a varicose eczema. Contact dermatitis. Patients with venous insufficiency have a disrupted epidermal barrier, making them more susceptible than the general population to contrast sensitization and subsequent dermatitis. Atrophy blanche. This is an endpoint of a variety of conditions, appears as atrophic plaques of ivory white skin or marble skin with telangiectasias. It represents late sequels of lipodermatosclerosis, where the skin has lost its nutrient blood flow. Lipodermatosclerosis. This is indurated plaque in the medial malleolus. Pain, anxiety, depression, inflammation, discoloration, skin thickening, and cellulitis. Treatment can be surgical, ligation trying of a vein to prevent blood flow, and vein striping, removal of the vein. And conservative treatment, it means compression. Types of varicose ulcers. Vasculogenic ulcers are commonly due to the cessation of blood or lymph flow into or out of the area. Post-traumatic or scar-associated ulcers develop because the scar tissue affects circulation around the wound, which leads to degeneration. Neurotrophic ulcers result from defective sensory innervation. In surgical practice, the commonest varicose ulcers are those caused by blood circulatory disorders of the extremities, chronic arterial or venous insufficiency. Varicose ulcers are commonly large and deep and located over the medial malleolus. Surrounding tissues are indurated and blotchy. The ulcers are unlikely to be tender on palpation. It is noteworthy that one of the diagnostic clues is a combination of ulcer and varicose veins. Post-thromboembolic ulcers result from chronic venous insufficiency in lower limb and are generally located around the medial malleoli. The size of an ulcer may range from tiny, a few centimeters in diameter, to gigantic, huge ulcers stretching circularly around the whole lower third of the leg in the form of a cuff. They are often superficial and have flat margins, their surface being covered by non-viable granulation tissues. The skin on the lower limb, particularly that around the ulcer, is edematous, firm and markedly indurated. Lymphedema and lymphatic edema is condition of localized swelling caused by a compromised lymphatic system. Signs. The most common manifestation of lymphedema is soft tissue swelling edema. As the disorder progresses, worsening edema and the skin changes including discoloration, varicose, wart-like hyperplasia, hyperkeratosis, papillomatosis, dermal thickening and ulcers may be seen. Additionally, there is increased risk of infection of the skin known as cellulitis. Diagnosis is generally based on signs and symptoms with testing used to rule out other potential causes. An accurate diagnosis and staging may help with management. A swollen limb can result from different conditions that require different treatments. Diagnostic of lymphedema is currently based on history, physical exam, and limb measurements, imaging studies such as lymphoscintigraphy and indocyanine green lymphography. Treatment: bandaging, it means compressive, intermittent pneumatic compression therapy, exercise, or surgery. And necrosis. Necrosis is the death of tissues of part of or a whole organ of the living body, a death of large groups of cells followed by acute inflammation due to some underlying pathologic processes, never physiologic, and divided into several types based on gross features. Causes: extensive crushing, severe pressure on tissues, vascular injuries, organ compression, bolus with compression of the vessels, leaving the tourniquet on a limb for a long time, vascular thrombosis and embolism, obliterating endartereitis, obliterating arteriosclerosis. Gross patterns of necrosis. Coagulative necrosis. Necrotic tissue that remains firm, cell shape and organ structure are preserved by coagulation of proteins, but the nucleus disappears. Characteristic of ischemic infarction of any organ except the brain. Area of infarcted tissue is often wedge-shaped, pointing to focus of vascular occlusion and pale. Red infarction arises in blood, re-enters and loosely organized tissue. Liquefactive necrosis. Necrotic tissue that becomes liquefied. Enzymatic lysis of cells and protein results in liquefaction. Characteristic of brain infarction. Proteolytic enzymes from microglial cells liquefy the brain. Abscess. Proteolytic enzymes from neutrophils liquefy tissue. And pancreatitis. Proteolytic enzymes from pancreas liquefy parenchyma of the pancreas itself. Gangrenous necrosis. Coagulative necrosis that resembles mummified. Characteristic of ischemia of lower limb and gastrointestinal tract. If superimposed infection of dead tissues occurs, then liquefative necrosis ensues. Wet gangrene. Caseous necrosis. Soft and friable necrotic tissue with cottage cheese-like appearance. Combination of coagulative and liquefative necrosis. Characteristic of granulomatosis inflammation due to tuberculosis or fungal infection. Sometimes you can hear terms gangrene of the lung or leg, but you never hear gangrene of the heart. Why do you think doctors don't use these names to all parts and organs of a human body? I give you 10 seconds to think. Okay, in the traditional way, doctors call all the parts of the organs which can contact with the external environment necrosis called gangrene, and all which can be organs which didn't contact with the external environment called necrosis. So lung via the bronchi and trachea can contact to the external environment. Pressure ulcers, another known as bedsores, are localized damage to the skin and or underlying tissue that usually occurs over a bony prominence as a result of usually long-term pressure, or pressure in combination with shear or friction. The most common sites are the skin overlying the sacrum, coccyx, heels and hips, though other sites can be affected, such as the elbows, knees, ankles, back and shoulders, or the back of the cranium. There are four mechanisms that contribute to pressure ulcer development. External pressure applied over an area of the body, especially over the bony prominences, can result in obstruction of the blood capillaries, which deprives tissues of oxygen and nutrients, causing ischemia, deficiency of blood in a particular area, hypoxia, inadequate amount of oxygen available to the cells, edema, inflammation, and finally necrosis and ulcer formation. Ulcers due to external pressure occur over the sacrum and coccyx, followed by the trochanter and the calcaneus. Friction is damaging to the superficial blood vessels directly under the skin. It occurs when two surfaces rub against each other. The skin over the elbows can be injured due to the friction. The back can also be injured when patients are pulled or slid over the bed sheets while being moved up in bed or transferred onto a stretcher. Shearing is a separation of the skin from underlying tissues. When a patient is partially sitting up in bed, their skin may stick to the sheet, making them susceptible to shearing in case underlying tissues move downward with the body towards the foot of the bed. This may also be possible on a patient who slides down while sitting in a chair. Moisture is also a common pressure ulcer culprit. Sweat, urine, feces, or excessive wound drainage can further exacerbate the damage done by pressure, friction and shear. It can contribute to maceration of surrounding skin, thus potentially expanding the deleterious effects of pressure ulcers. Stages of pressure ulcers. Stage 1. Intact skin with non-blanchable redness of a localized area, usually over a bony prominence. The darkly pigmented skin may not be visible blanching. Its color may differ from the surrounding area. The area differs in characteristics such as thickness and temperature as compared to adjacent tissue. Stage 1 may be difficult to detect in individuals with dark skin tones, may indicate at risk persons, heralding signs of risk. Stage 2. Partial thickness, loss of dermis presenting as a shallow open ulcer with a red-pink wound bed without slough. May also present as an intact or open ruptured serum-filled blister. Presents as a shiny or dry shallow ulcer without slough or bruising. This stage should not be used to describe skin tears, tape burns, perineal dermatitis, maceration, or excoriation. Stage 3. Full thickness tissue loss. Subcutaneous fat may be visible, but bone, tendon and muscle are not exposed. Slough may be present but does not obscure the depth of tissue loss. May include underlying and tunneling. The depth of stage 3 pressure ulcers varies by anatomical location. The bridge of the nose, ear, malleus do not have adipose subcutaneous tissue, and stage 3 ulcers can be shallow. In contrast, areas of significant adiposity can develop extremely deep stage 3 pressure ulcers. Bone tendon is not visible or directly palpable. Stage 4. Full thickness tissue loss with exposed bone, tendon or muscle. Slough or eschar may be present on some parts of the wound bed, often include undermining and tunneling. The depth of a stage 4 pressure also varies by anatomical location. The bridge of the nose, ear, occiput and malleus do not have adipose subcutaneous tissue, and these ulcers can be shallow. Stage 4 ulcers can extend into muscle and or supporting structures, joints, making osteomyelitis likely to occur. Exposed bone tendon is visible or directly palpable. Unstageable. Full thickness tissue loss is in which actual depth of the ulcer is completely obscured by slough and or eschar in the wound bed, until enough slough and or eschar is removed to expose the base of the wound. The true depth and therefore stage cannot be determined. Stable. Eschar on the heels is importantly protective and should not be removed. Suspected deep tissue injury. A purple or maroon localized area of discolored intact skin of blood-filled blister due to damage of underlying soft tissue from pressure and or shear. The area may be preceded by tissue that is painful, firm, mushy, bodgy, warmer or cooler as compared to adjacent tissue. A deep tissue injury may be difficult to detect in individuals with dark skin tones. Evolution may include a thin blister over a dark wound bed. The wound may further evolve and become covered by thin eschar. Evolution of the pressure ulcer may be rapid, exposing additional layers of tissue, even with optimal treatment. Consider bedfast or chairfast individuals to be at risk of pressure ulcer development. Consider the impact of mobility limitation on pressure ulcer risk. Being bedfast or chairfast are usually described as limitation of activity. A reduction in an individual's frequency of movement or ability to move is usually described as having a mobility limitation. Complete a comprehensive risk assessment for bedfast or chairfast individuals to guide preventive interventions. Mobility and active limitation can be considered a necessary condition for pressure ulcer development. In the absence of these conditions, other risk factors should not result in a pressure ulcer. Consider individuals with a category stage 1 pressure ulcer to be at risk of progression new category stage 2 and greater pressure ulcers. Consider individuals with an existing pressure ulcers, any category stage, to be at risk of additional pressure ulcers. Consider the general status of the skin and pressure ulcer risk. Consider the impact of the following factors on an individual's risk of pressure ulcer development: perfusion and oxygenation, poor nutritional status, and increased skin moisture. Consider the potential impact of the following factors: increased body temperature, advanced age, sensory perception, hematological measures, and general health status. Preventive skin care. Avoiding positioning the individual on the area of erythema whenever possible. Erythema indicates that the body has not recovered from the previous loading and requires further respite from repeated loading. Second, keep the skin clean and dry. Use a pH-balanced skin cleanser. 3. Do not massage or vigorously rub skin that is at risk of pressure ulcers, as well as being painful. Friction massage can cause mild tissue destruction or provoke inflammatory reactions, particularly in frail older adults. Develop and implement an individualized continence management plan. Cleanse the skin promptly following episode of incontinence. 5. Protect the skin from exposure to excessive moisture with a barrier product in order to reduce the risk of pressure damage. It is important to note that skin damage from moisture is not a pressure ulcer, but the presence of skin damage from moisture may increase the risk of pressure ulceration. Do not use dimethyl sulfoxide, dimexid in Russian. Emerging therapies for prevention of pressure ulcers. Microclimate control. You must control temperature and moisture. Consider applying a polyurethane foam dressing to bony prominences. Assess the skin for signs of pressure ulcer development to each dressing change, or at least daily. Replace the prophylactic dressing if it becomes damaged, displaced, loosened, or excessively moist. Consider the use of electrical stimulation for anatomical location at risk of pressure ulcer development in spinal cord injury patients. Nutrition in pressure ulcer prevention and treatment. Provide individualized energy intake based on underlying medical condition and level of activity. Provide 30 to 35 calories per kilogram body weight for adults at risk of a pressure ulcer or with pressure ulcer who are assessed as being at risk of malnutrition. Consider enteral or parenteral nutritional support when oral intake is inadequate. This must be consistent with the individual's goal. Provide adequate protein for positive nitrogen balance for those assessed to be at risk of a pressure ulcer. Offer 1.25 or 1 to 1.5 grams protein per kilogram of body weight daily. Assess renal function to ensure that high levels of protein are appropriate for the individuals. Provide and encourage adequate daily fluid intake for hydration for an individual assessed to be at risk of or with a pressure ulcer. This must be consistent with the individual's comorbid condition and goals. Monitor individuals for signs and symptoms of dehydration, including change in weight, skin turgor, urine output, elevated serum sodium, and/or calculated serum osmolality. Provide additional fluid for individuals with dehydration, elevated temperature, vomited, profuse sweating, diarrhea, or heavily exuding bones. Use a pressure redistribution surface to fluid pressure points. At each rotation, assess other body areas. Wherever possible, do not position an individual on an existing pressure ulcer. Assess and document physical characteristics including location of pressure ulcer, category or stage, size, tissue type, color, peri-wound condition, it means around wound, wound edges, sharp or blunt, sinus tracts, undermining, tunneling, exudate, and odor. Debridement of pressure ulcers. Necrotic tissue should be removed in most pressure ulcers. The heel is an exception in many cases when the limb has an inadequate blood supply. Necrotic tissue is an ideal area for bacterial growth, which has the ability to greatly compromise wound healing. There are 5 ways to remove necrotic tissues. Autolytic debridement is the use of moist dressing to promote autolysis with the body's own enzymes and white blood cells. It is a slow process but mostly painless. It is the most effective in individuals with a properly functioning immune system. Biological debridement or maggot debridement therapy is the use of medical maggots to feed on necrotic tissue and therefore clean the wound of excess bacteria. Although this fell out of favor for many years, in January 2004, even in the United States, it was approved as a medical device. Chemical debridement or enzymatic debridement is the use of prescribed enzymes that promotes the removal of necrotic tissue, as a streptokinase or urokinase. Mechanical debridement is the use of debriding dressings, whirlpool of ultrasound for swath in a stable wound. Surgical debridement or sharp debridement is the fastest method, as it allows a surgeon to quickly remove dead tissue. Thank you for your attention. I hope you knew something new from this lecture. You can write your questions in the comments or in the chat in the LMS.